Okay, Dr. Kumar, can you hear us?
Yeah, hi, good morning.
Hello, sir. This is Dr. Parikh, and we have an esteemed group here, Dr. Buzman from Poland, Dr. Karthikeyan, Dr. Kroll, Dr. Labores, and Dr. Abradis. We're anxiously waiting your case. Thank you, sir.
Hi, so good morning to all of you. I am Dr. Viveka Kumar, Director, Cath Lab. So,
We hear you
with,
well.
with me, the team is there, Dr. Vivek, who is consultant here. Hello. And we have got anesthetic colleague, Chief of Technician, Sushil. So we have got a case here,
Wonderful. We're waiting for your...
70 years old lady whom we had done angioplasty and stenting of LED in 2007, and she had recurrence of angina, and her stress echo was positive in inferobasal area and anterior wall. So we had done her cardiac catheterization. Can we have the angiogram, please? Can you show the angiograms? So she has, can you see the angiograms?
we are seeing you. We are not seeing the angiograms.
Can you?
Yes, we're now seeing it.
Can you show the? Okay. So this is a left dominant system, and you could see that LAD has severe stenosis just proximal to the previous stent. That was a drug-eluting stent done in 2007. Can we have another view, please? One small OM has disease. The LAD distal has mild to moderate plaquing at the site of a diagonal. And circumflex you could see at the origin of left PDA. LPDA has got a severe stenosis.
Yes, we see that. Also seems to be a tight diagonal.
Can it be other views? Yeah. So diagonal ostium is also diagonal. That's a moderate size diagonal. Looks like that apparently has come from the stent segment.
Yes.
Previous stent segment. So our plan is to treat the LPDA and the proximal LAD and diagonal.
Wonderful. Very clear. So what size guide is this,
Yeah,
Dr.
so any
Kumar?
strategies from the panel chairpersons?
Okay, so Dr.
So this is 7 French guide.
Okay, so it's a femoral 7 French guide. Okay. Dr. Buzman, how would you handle this LAD diagonal?
Yeah, yeah.
I think it's a good example of multivessel disease, and I would suggest to use Excel study protocol to assess the severity of the lesions, especially this proximal LAD. There is some maybe intermediate lesions distally after the stent in distal. So maybe the measurement of FFR sometimes give us some information about how severe is the lesion and whether we need to stent it. And of course, I find this diagonal branch as an important one because it supplies the blood to the lateral wall. So I find it as an important and critical narrowing of the artery. Additionally, there is a lesion in distal circ. It's a little bit challenge, but again, it supplies the blood to posterior wall. So one should consider whether it should be done at this stage procedures. So that's up to operator, but I would think about this lesion as well.
Okay, Dr. Kumar, so I think in our particular angiographic transmission view, the diag is very tight, the left PDA is very tight, the proximity seems to be intermediate, but in your view it may be severe, and so the question of physiologic significance was brought up as just a discussion point. clearly,
yeah.
we agree with the approach of treating.
Yeah, so that's good. So
So go ahead
Ready?
and proceed. Let us know what your thoughts are.
yeah, so we felt that we would fix the distal circ first, and we had information of stress perfusion imaging that both the LAD territory and the posterior wall having reversible ischemia.
Right.
So we had committed to treat the proximal LAD lesion and the circumflex distal. So we have just wired the distal circumflex, and we wanted to do the distal circ. And can we show? So this was very fibrotic lesion. We tried to pre-dilate with 2 millimeter balloon. Can you show the pre-dilatation? So this is the wiring of the distal circumflex, and you could see that the balloon we have placed across, but it's slipping, either proximally or going distally. So we have taken a longer balloon, and the plan was to use as the patient is international patient and they wanted absorbable scaffold. So we had thought of implanting Meres stent. So we wanted to prepare the bed very well. So we have done 1:1 artery ratio pre-dilatation after dilating with 2 millimeter balloon. We have done with a 2.5 millimeter longish balloon, and it has completely opened up. So it's very, very important that we know that the bed is well prepared before we can commit for the absorbable scaffold. So this looks like, so we are trying to sort out there is some issue with the OCT machine. So we have planned for an Meres 102.5 into 24 absorbable scaffold. So we'll implant that, and hopefully by that time OCT would be working. So we'll do a post run also.
So, Dr. Kumar, is this a compliant balloon, or do you like
Meres,
to
can you
prep
show
with a
the
non-compliant balloon for VRS? Are you using a non-compliant balloon?
So this is non-compliant balloon. So we non-compliant balloon. Yes,
Okay.
we are using, and with the high pressure we went up to 14, 16. And what we do is that when we inflate the balloon, we see the, with the contrast, it looks like that it's almost 1:1. But
Yes.
obviously we need to check it with the imaging technique also. So this is Meres 2.5 into 24 balloon, and as you know, we can up the size up to almost 0.75 millimeter if the need be. So we'll first implant the Meres stent in the absorbable scaffold. This is from Merrill Life Sciences, almost 100 micron thickness, and we had done a study with this Indian patients. We had recruited around 16 patients, and we had very good outcome. In fact, today we have posted 2-year follow-up of Meres check angiogram also, the proximal LED we had done.
Well, that's, I think,
So
very,
this
very
is, can you
exciting.
show the Meres stent here? Can you focus on this camera?
As you might
Yeah.
have heard
So
and
I'd request you
seen,
to focus on this so you could see.
in the United States, they've removed the Abbott product, but I'm very happy to see that Meres is doing well with very nice data. We see it. We see your stent.
Yeah. So I think personally, though the Abbott has withdrawn the stent globally, the absorbable scaffold, but that was kind of very thick strut stent, and they might come back with the thinner strut. And we still feel that the absorbable technology is not yet completely out of the practice. So probably it will make a comeback with next generation scaffolds. So I personally feel that the Meres is probably better generation because the thickness is better, and you can see that the crossing is also in such a tortuous artery. It's nicely crossed in, and you could see that this longish stent 24 millimeter has easily crossed into the distal circumflex.
Yes, that's very
So
nice.
we will properly place it and then inflate. So as you know, the experience from absorbable scaffold, we had done around 1,000 scaffolds in our experience, and we need to use the same principles of deployment. We need to go slow, gradually inflate, and then do a good post dilatation. So it is very mandatory that good apposition, as you know that in absorb data also post dilatation was very, very important. So we'll take a check shoot and position it. So you could see that it's nicely covered the lesion, so all the segment which was pre-dilated, is covering by the stent. You could see that the markers are very nicely, easily visible in this. So you can see the proximal balloon marker followed by the, can you show the, I hope you can appreciate the proximal balloon marker, and then there is a scaffold marker which is almost 0.5 millimeter inside the stent, and the distal marker also. So it's nicely placed. Can we go up on the balloon 2 atmospheres? So we'll inflate very slowly. Four, 6, 8, nominal. So 9 atmosphere is the nominal. We'll go up to 10 atmosphere for 30 seconds. So 10 atmosphere we usually keep for 30 seconds, unlike the metallic DES where the quick inflation and deflation could be there. But since it's a plastic, it might take longer to inflate, and so we need to give a sustained inflation for some time.
This is a very nice demonstration.
The patient is also tolerating it very well.
Of patience with the expansion to make sure that you get full apposition, and you're obviously going to post-dilate this, but we see clearly that it has grown in the mid-segment where there was a waist.
Yeah.
Stent boost.
Yeah. So you could see that I'll do a stent boost also just to show the markers here. So there are 3 markers, radio-opaque markers in the proximal segment and 3 in the distal segment. Can you just focus it? Remove the black portion of the wire from the focus. Focus on the stent boost, please. Could you just show the, ready? Is stent boost ready? Yeah. So I hope you can see the stent boost images. Just proximal to the balloon marker, you could see the 3 stent markers. So scaffold markers, 3 in the proximal segment and 3 in the distal segment. So this is unique and different from the previously existing absorbable scaffold.
Yeah, we were able to see a little bit of
Can you
that,
just
yes.
show the stent boost images? Okay.
We clearly see the 3.
Okay,
3
so we'll
markers,
remove the
both
balloon
proximal and distal.
and take a check shot. Yeah, yeah, yeah. Excellent. Check shot. So you could do a check shot here, and you see it's nicely red. The size looks okay. So we'll do a post dilatation before we do an OCT. 2.5 balloon, 20 NC balloon.
Yeah, we are ready with it. 2.75?
Hmm.
2.75.
So you're taking a slightly larger non-compliant
Yeah,
balloon.
so proximal segment looks like 2.5. Yeah, so we have taken 2.75, 10 non-compliant balloon. So the key to have good outcome with the absorbable scaffold is to do an aggressive post dilatation with slightly larger balloon. So that's why we have taken a slightly quarter size bigger balloon. And one of the problems with the absorbable scaffold is that you can't really see the scaffold, but with the 3 markers it makes job easy. You could clearly see.
Stent boost.
Can you focus here? So first we will try to dilate at the place where there was a waist. Cine, please. So we are clearly well within the scaffold. We have done a stent boost also. So we'll first dilate at this place.
And in contradistinction to the Abbott
So
product,
distal
this
marker
is,
will dilate, go up to 12.
this is so much easier to see the markers.
Yes, so visibility is quite good. So we can't miss all the 3 markers. So 14, 16. So this is the Mosaic non-compliant balloon, 2.75 into 10. So we are going at a high pressure, 20 atmospheres, and we can see good expansion. And we'll dilate the whole scaffold from distal to proximal. We'll come to the proximal segment, 18, 20. Seconds. You have the catheter ready? Negative. And the proximal most part at the three confluence of the three markers, 18, 20. So up to 20 atmosphere, good post dilatation. Ready?
It's nice expansion. It looks like it's no residual waste.
Yeah, looks like it's expanded well. Yeah, no residual waste, exactly. So we'll take a check shoot. Shoot this. Yeah. Okay, so that's well expanded. Now we will come to, because still the OCT is not working, so at the end of the case we would do an OCT again. We'll go to the LED diagonal lesion. If it is not getting ready, can we do the IVUS?
Yeah, we can prepare IVUS catheter, please.
One thing I have noticed is that in some of our
So now we will wire the LED and diagonal.
yeah, if we don't have OCT, the high def IVUS is very useful for PRS. And I think that the imaging is quite good. So what is your strategy, Dr. Kumar, for LED diagonal?
Yeah, so we intend to do an imaging of the proximal LED. We have functional significance in the form of the stress MPI that shows that the LED segment is also significant. Yeah, because that showed reversible ischemia in LED territory. And
Another
we'll just
wire.
see if we can do FFR. If the machine is functional, we can do an FFR also. So first we will wire the LED and diagonal, because we are not sure whether diagonal is coming through the stent or it's proximal to the stented segment. We have just wired the LED and we are just going to wire the diagonal. Just a check shot for the final shot for the circ. Vivek?
Yes, sir. Same view. Ready with injection.
So we'll just see the distal circ. That looks nice and good. So it's well expanded stent. There is no issues there. We are just going to wire the diagonal. Can we have any of the imaging techniques ready?
OCT is ready.
OCT is ready. Okay. LA caudal चलेगा.
LA caudal, please.
Check. So diagonal is coming at a very posteriorly from the artery.
Yeah, it has also a bifurcation itself.
So we'll try to pre-dilate the diagonal first. Yes, yeah. So diagonal also has a bifurcation there.
It seems to
Can
come
we
off
have
right
the-
where the stent is.
2 millimeter balloon for the diagonal. Yes, yes.
2
it
millimeter.
does.
Yeah.
We'll try to see
250.
whether the balloon goes through that or not. Yes. So this is a mosaic balloon, that is NC balloon. So whenever we go through the stent strut and try to dilate, always take an NC balloon. This is the Merrill mosaic balloon. That's very good, and non-compliant balloons are very good. We'll first try and cross and see how it goes.
OCT is ready.
OCT is ready now.
Yeah.
Acha. So the diagonal has gone, the balloon has gone easily in the diagonal.
And that's a good sign. It's
Can we have a check?
even though it may be across the
Yeah.
stent, it's quite open the origin. But
Sir.
there's a tight focal region.
Yeah. To 6/8. Are you in the bigger one? Yeah, so waist has gone. Can you see that there was a tight waist that has gone now? Negative. 9/10. So now we can use a regular bifurcation strategy for this. Negative. Short, please. So can you see the images? Because it looks after dilatation good, and then probably it's coming just proximal to the previous stent.
Yep. Yeah, we see it well, and we also see that you were
So
able to expand the
what
diagonal.
kind of
I think you need to just
Yeah.
stent the diagonal and leave, park it right at the ostium and have a blocking balloon. You don't need to get into the LAD at all. The ostium is fairly well preserved.
Yeah, so that's what yes.
And you just have to decide
Can we
what you
see
wanna
the
do with
in
LAD.
another view also? Epicaudal.
Epicaudal, please.
Yeah. So we will first, though the functionally it looks significant, so let's see how it looks. Yeah, so we have a space for the diagonal stent.
Yeah. So it's a large diag.
So what does the panel feel? What should we do with the LAD?
Well, yeah, I would want to image it if you have already opened
Imaging.
OCT.
Should we do
IVUS, why don't you
OCT?
IVUS it? LAD and C.
Yeah. Yes.
We are ready with the OCT?
So we would. So we are of the same view. We will.
Yeah,
Yeah.
LED.
So we are taking the OCT since we have already opened it.
This side, sir.
So if the stent is needed, Maris
right.
might be what you think a good option for this proximum LAD. It looks like rather
Light.
soft tissue. If it's confirmed with IVUS, that might be the
Yes,
option.
yes.
Especially in this way, you prevent another metal stent implantation, and you may implant bioresorbable scaffold which disappear within, let's say,
Yes.
half or 1 year.
Yeah, exactly. So that's what we feel, and so we are passing the OCT catheter right in. When we bring it closer. Or are they? Yes, यहीं पे?
Rotranial.
So we are right into the previous stent in the LAD.
Yeah, we are ready.
So we are ready for the imaging. Can we go? Yeah. Yeah, go. Say that when to inject.
Should I go for the pullback, sir?
Yeah.
Yeah.
So once I press the pullback, you will have 15 seconds to insert
Okay.
start, sir.
Can you show the images there? Direct, live.
Live, fast. ये लाइव कैसे जाएगी image? जा रही है?
Can you see on the screen the images?
Yeah, we see the images very nicely.
Yes. Yeah. ठीक है.
So we see the takeoff of the diagonal, and that's probably where the most disease is, but I don't know how tight it is.
Mhm.
Is the image good
Yes,
enough or
yeah.
do we need to take
Mm-hmm.
Sure.
Mm-hmm. LED proximal दिखाओ. Slowly, can you just pull back?
From the stent it.
Mm. So go to the proximal part of the stent. The place where the diagonal is coming, just proximal to that.
So we were discussing that probably proximal part of LED seems quite nice, and the narrowest part is just distal to
Yeah,
diagonal.
yeah.
Right, just at the diagonal, right beyond it,
Right.
yeah.
Mm.
Very focal lesion.
Yes, yes. Yes, yes. Yeah, yeah. Yeah, very focal. Yes, yes. So I think we'll have to come into the, so overlap with the previous stent and treat the diagonal. So we would try and do stent the diagonal and do a mini crush.
Yeah, I mean,
And
I think you
then
can
do a
just,
final
just,
kissing.
Just do a.
Do they agree with that plan?
Yeah, yeah, I think just do. You don't even need a mini crush, but yeah, it's very close. Just get into the ostium with a balloon and the LED and stent the diagonal, and then you can stent the LED.
Yeah, yeah, yeah. Yeah, yeah. So that's what we are planning to do. So I think, can we have the
I don't have experience with
one
BRS over
3O balloon for LED?
DS and the panel.
Mhm.
Any experience?
Mm-hmm. Mm-hmm.
I believe this
So since we have space in the diagonal, we will not, do a crush with the BRS.
I don't think you need a crush. Yeah. I think you can land it at the ostium nicely without
Yes,
having a
yeah.
crush.
So we can go with the 2.5 into here. So give a balloon for the LED and BRS 2.5 into 19 for the diagonal.
Why not we try a branch in this?
Hmm?
Branch.
Branch needs to be next. 3 into 13. And
we are
What's
good
the
in this
vessel
case
size there?
by
Reference vessel?
presence of positive functional tests
Yeah.
previously as imaging tests, but routinely
Yeah.
part of the patients come to the cath lab with ambiguous tests. So for me, this case illustrates the
Yeah.
importance of having capability to do FFI in your cath lab and verify your
Balloon.
decisions functionally.
I think that's very important.
yeah.
Absolutely right. There's some sort of pre-planning or
Yes.
and
Yeah, that's
procedural
absolutely right. Yeah.
physiology.
This is a 3 balloon.
balloon LED. Yeah, so that's absolutely right. I think had we not had the information of stress perfusion imaging, just in order to curtail the cost, we needed that. We are not doing FFR because we had already committed this. Yes. 2.519. So you are taking in Meres 2.519 to the diagonal. And one balloon will keep in the LED. And after that, we will stent the LED.
Now, teach us something, Dr. Kumar, with your experience with BRS. When are you
Yeah.
concerned
Mm-hmm.
that you're going to do more predilatation or plaque modification? Is it just under expansion? Is it recoil? Is it when do you do more before you prep it and place a BRS?
Yeah, so it's the recoil and under expansion both, I would say. So it's like it's under expansion is more concerning. Recoil means that the lesion has already given way. So if we give scaffold support, it might remain open. But under expansion is not acceptable at all because then the BRS may not expand at all and can cause problem. So we are having some issues in trackability of in the tortuous segment of the scaffold. Now we are across. check. Okay, so we're in the bigger branch. Yeah. Yes. Yeah. And can we have the balloon in the LED?
Yeah, ostium looks like a good placement. You can
3
even-
into
You can even
30,
come back
yes.
if you wanted.
Yeah, yeah, yeah. Yeah. You will finally position a little bit proximally. We'll come back.
A question from Dr. Guzman whether the scaffold is in the largest branch.
Yes. So we deliberately put it in the largest branch.
Yeah, it's the top one.
Yeah. So you place the NC balloon across the diagonal ostium just to make sure that nothing pops in.
Dribble.
Can we have a check shot now? Connect, please. Who is on the stent?
Stop.
So we'll come a shade inside the diagonal. ठीक है ना? So I think
Looks good.
because remember there is 5 millimeter extra scaffold beyond the marker. So we'll take a final shoot and yeah, go up on the diagonal inflation.
Yeah.
The stent, yeah.
Slowly.
Slowly again, 2, 4, 6. Hmm. 9. 10. We hold on for 30 seconds. Okay, so 30 seconds up. Negative. Deflate. Check shot. So we'll pull slightly in the LED and then do a slightly higher pressure dilatation in the scaffold. Yeah, 10, 12 again on the scaffold. Yeah, 14, negative. So we wanted to flare up the proximal part completely. Now we'll take a check shoot. On the LED, 6, 8, negative. So we just want to make sure that nothing is obstructing the second scaffold. Yeah, we'll take a check shoot. Yeah. Huh? Okay. Check shoot please. ठीक है. Okay.
Looks like the placement is good.
Mm-hmm.
You have a very large segment of the LED. You could put a
Yeah.
stent in that. Done.
Yeah. Mm-hmm. So can we come to the, so with the side wire jailing is not an issue with BRS because it's quite easily, it's a plastic, so side wire can easily slip out of that, and so that's not a big issue. So we'll keep the wire there and we'll take another scaffold for LED and then we do the imaging.
Any thoughts from the panel? You've done this differently at home, Dr. Kroll.
So in this view, we'll take. So any comments from the panel, or they agree with this plan?
Putting a next
Are recorded.
In the LED or in the
Yeah.
diagonal. OCT in the diagonal.
LED.
So we'll do, as Dr. Crowe said, we'll pass an OCT into the LED again. That's what you want?
Yes.
So can we have the OCT wire, please? So we'll do another imaging in the LED and see how it looks.
Seems like almost a 3-5 vessel LED.
So what was the size on the LED OCT, the last image? So it looked 3.25 or something like that.
While we were waiting OCT images, I want to ask panel around, does size of the vessel influence your decision whether to go with DES or BRS?
Any thoughts?
Smallish vessels?
We have 3.5 size.
Yeah, I mean, clearly, our experience in the United States is limited with BRS, of course. But one
Kitna hai?
thing we were not doing is anything smaller than 2.5. Absolutely not. Really, the sweet spot is between 3 and 3.5 for BRS. But we are seeing, as you see with Dr. Kumar,
So it proximal most segment, it shows
in
around
both
2.
segments, the diag and the left PDA.
More distally, more distally.
Thinner struts. So.
Distal, distal,
This is proximal, sir. This is proximal.
दिखाओ इधर करो.
distally.
From one side, we know that any stand, especially biodegradable scaffold, may cause some problems in small vessels. But on the other hand, it might be tempting
और आ
to
गया.
prove the concept of using BRS in small vessels because they dissolve and potentially nothing will be left there.
और आ गया.
So I think that would
can we have a
probably be a part
shoot?
of next
Are you ready?
clinical studies.
Pull back.
Whether we can use bioresorbable stents in this kind of medium size or small
Ready?
size vessels.
Yeah.
But still
Say whenever.
just ballooning is a good option as well.
डालो. देर कर दी. Can we have another one?
Another shoot, please. You have to save an after.
Give me that. Should I record it?
So again,
Maybe additional point, our worries come from the absorb stent BVS, which is a lot larger profile, and Maris is a much more favorable profile.
Right. Yeah, I was actually impressed how the BRS tracked on that diagonal. Let's see.
Yeah, so it's much more trackable BRS. So we have done another OCT. I think you can see the images there. And the proximal segment looks like 3.25, something like that.
yes, sir. Just go distally now. Hold it here.
So this
Just
is distal.
slightly distal. Distal.
Proximal
Yes,
bola.
proximal. Distal, please.
So we'll take a 3.5 into 18 BRS, yeah?
10 mark.
Yeah, I mean, you have a dissection right at the origin of the diagonal. You need to stamp
Yep.
that. And,
Yeah.
you have a nice
Distal
landing
down.
zone.
Distally,
Yeah.
Yes, measure it.
And the placement
Yes,
of
we'll
your
do that.
side branch stent was perfect. There's no struts hanging in the lumen.
Yes, protrusion, yes. So can we have 3.5 into 18 BRS?
3.5 19 feet.
19, yes. So we have 3.5, 19 BRS, so we'll overlap with the previous 10.
3.37 is the maximum.
So maximum dia is coming 3.37. So 3.5 should be okay.
Yeah. Now, once you put this across the origin of the diagonal, what is the experience with doing kissing balloon inflations? Is that a no-no with Merez, like it was with BRS, Abbott?
So kissing less than, yeah, so it's the same line, yes, because it's a much thinner strut. So anything which is more than 2 millimeter balloon, I think that's absolute no.
Okay. So unless
Well,
you
we see how it goes, whether that is required or not, because we have not really come into the LED.
Yeah.
So this is tracked very well. So now we'll position it accurately at the LED ostium with the overlapping with the previous stent.
Some more. That's it. Thank you.
Epicaudal, slightly epi side.
Epicaudal, shallow epicaudal.
Check please. Will come little proximal. Short. Yeah, so that looks good. Check again. So we are right at the ostium of the LED. So we'll go here. Go. Inflation 9-10. Slowly. 3.5 balloon. Cut look. 10. So we are at the 12 atmosphere. You can see that the segment which is bent, it's some residual things in.
Deflate.
Negative.
Deflate.
So we are 30-second plus in negative. Deflation please. Yeah. So now pressure had dropped, now it's coming up. Can you come to RO and give a stent boost? So we'll show an stent boost. How does it look? Whether we can appreciate in previous stent the metallic stent and the platinum markers of this. Boost ready? So there are too many dots to confuse all of us, isn't it? But we can clearly see that the proximal segment there are 3 dots, and then you can see the 3 dots in the previous stent, and they are quite linear there. And then we can see the diagonal scaffold dots as well. So we'll take a check shot and see how it looks like, and then we do an OCT again. Shot.
Yeah, ready.
So there is still some indentation is there at the diagonal area. So we'll do with 3.5 NC balloon,
Yeah,
high
I think
pressure
before you do
dilatation.
OCT, yeah.
Can we have a 3.5 into 12? So how many more minutes to go? So we are doing an aggressive post dilatation with 3.5.
Yeah, I think you'll get a nice expansion with 3.5 right there. We were just talking, Dr. Buzman and I, that you see the outline of probably a deep wall dissection, which was
Yeah.
created, from the pre-dill, which is okay. And as long as you have expansion and apposition
Yeah,
on
yeah. Mhm.
OCT, you're okay. I think the big thing with BRS we learned in the United States,
Mhm.
unlike DES,
Yeah.
where malapposition you get away with, in
Yeah.
BRS, malapposition is potentially fraught
Yeah,
with
here you
major
can't,
problems.
yes. Yeah, just that not tolerated. Yeah, yeah, absolutely, that's right. So in fact, all the adverse outcomes are there in, undersizing and non-expansion, non-apposition. So it's clearly we can see that we are at the distal edge, 14, 16, 18, 20. Yeah. Hold for some time. Negative. Then we'll bring to the segment where we really, so go up 18, 20 here. Yeah.
We have another
Yeah.
5 minutes or so with you, so I think this is perfect timing, a beautiful demonstration.
Okay,
by
so
your
we'll
team.
take an OCT run also. Yeah. Yeah.
Looks like a nice expansion there.
Thank you. So go up again, 18, 20. Yeah. Again. Yeah. So that looks to be expanded now. We'll keep it for 30 seconds there. Can we get the OCT ready? Negative. Hmm. Get the OCT catheter. Okay. And one cranial view. Yeah. So we'll take an OCT suit there. So in both the views it looks nice and expanded. We'll confirm it by the OCT. Are you ready? Hold it the wire.
Really looking very nice. I think here the 7 French guide has given you a lot of stability as well. No issues with tracking.
Yeah, so that's comfort. Yes, yes. So the catheter has gone nicely in. Yeah.
Catheter in position.
Say when to inject. Are you ready?
Please tell me when to inject.
Yeah, go. So these are the images. Can you show the images there? You can see that nicely opposed box. Can you show it on the screen, please? वहाँ पे दिखाओ. Yeah. Yeah. Can you see that on the
Yes,
screen now?
We do, yes.
Yeah.
Yeah. So can you show the transition from the DES to BRS? So it looks very well, nicely expanded and very good apposition in the prox.
Yeah, and the
Can you
inflow
show
looks
one run
very
again,
clean
please?
As well, I think you hit it right on the ostium with the LED. So I congratulate you.
yeah.
It's,
Yes, yes, yeah.
Side branch ostium.
That was the side bridge, yeah. So I think we'll, so it looks okay, so we don't need any further dilatation and the result looks pretty good.
yeah, the 3.5 was perfect.
Yeah, perfect, yes. Good, so we'll withdraw the OCT catheter and then withdraw the wires and take a final picture for you. Hold it. Ariocaudal.
Okay, we'll stay with you for another
Can we get the ariocaudal?
minute or two, and then we'll bid you goodbye. But I want to thank you and congratulate you, Dr. Kumar.
Okay,
An
good.
absolutely wonderful demonstration. If we can
Yeah,
see
thank
the
you very
angio,
much,
that would be
and
great.
Thank you to panelists and chairpersons. Yeah, so can you show the last shots? Minus. So these are the final shots without wires and all. Minus.
I'm very
Next.
impressed with the side branch diagonal as well.
Give one aleocranial also. Yeah. Yes. Yeah. We'll take an aleocranial view as well and just do. So you can see that there is a nice, well expanded stent in proximal LED, the diagonal also. the main branch of the diagonal is doing fine, and then we could see the distal circumflex and LPDA, that's also fine. So we'll take a leave, we'll do a perclose to this lady because she's tired, and
Thank you and congratulations to your theme, Dr. Kumar.
can we have the wire, please? So I thank, thank you, and I thank Merrill Life Sciences and all the chairpersons and panelists. Thank you for having a nice time with us, and thank you for your comments and observations. Thank you once
Wonderful
again.
demonstration. Thank you.